accept this invitation to speak. So in the next half an hour, I'll briefly speak about cardiac amyloidosis. This is my disclosure. So amyloid refers to any abnormal extracellular fibrillar protein that deposits in the tissues. So the diagnosis on histology is made with the pathognomonic green birefringence after Congo red staining visualized under polarized light. There are more than 30 different proteins that can form amyloid in vivo, and the type of protein that misfolds and forms amyloid is the basis of the modern classification. Whilst many different proteins can misfold and form amyloid, there are two main types of amyloid that can cause cardiac amyloidosis. So light chain amyloidosis and ATTR, so transthyretin amyloidosis. So light chain amyloidosis is a systemic illness where there is a plasma cell dyscrasia that is produced in the bone marrow and can produce free light chains that can then misfold and deposits into the different organ and tissues as amyloid. Any organ can be involved, so the phenotypic presentation strictly depends on the pattern of organ involvement. So when the soft tissue involvement, you typically see macroglossia and periorbital bruising. Then you can see nail dystrophy, carpal tunnel, often bilateral. Patients that do present with renal amyloid, they usually present with nephrotic range proteinuria and reduced eGFR. And patients with cardiac amyloidosis typically present with shortness of breath. The other main type of amyloidosis is ATTR or transthyretin amyloid. In transthyretin amyloid, there's a protein called transthyretin that is normally produced by the liver, but in this instance it misfolds and deposits as amyloid into the different organ and tissues. There are two main types of cardiac amyloidosis. Wild type ATTR amyloidosis, where the phenotype is a predominant cardiomyopathic phenotype, is emerging as an increasingly recognized cause of heart failure in the elderly, and there's a clear male prevalence, with 95% of the patients being male. The presentation is usually shortness of breath, and in autopsy studies, roughly 25% of men over the age of 85 have got amyloid deposits. So the expectation is that in the next few years, there will be an exponential increase in the diagnosis of this disease. The other main type of transthyretin amyloidosis is called hereditary ATTR amyloidosis, and the amyloidosis is hereditary when the TTR gene presents a genotypic variant. In terms of clinical phenotype, hereditary ATTR amyloidosis can present with only a cardiomyopathic phenotype. A typical example is the V122I variant that is present in up to 4% of acrocardium. Or there are variants that do present with only or predominant neuropathic phenotype, like the B30MET variant. But there are several variants that have got a mixed phenotype with cardiomyopathy and neuropathy. Neuropathy that can be peripheral neuropathy, but also autonomic dysfunction. So what do we want from an imaging technique when we think about a disease such as cardiac amyloidosis? So these are the different steps that we want to go through when we develop a new imaging technique or a new imaging biomarker. So what we want is we want to be able to diagnose disease. So we want to be able to distinguish health and a disease. We want to be able to detect disease early. We want to be able to diagnose disease with a high diagnostic accuracy, so high sensitivity and specificity. We want to be able to predict prognosis, stratify patient, track changes over time. But we need to bear in mind that what we really want is to be able to track changes over time, guide treatment strategy, and by doing so, stratify patient's prognosis and improve patient prognosis. So during this presentation, I will take you through all these different steps in CMR in cardiac amyloidosis. So let's start from the diagnosis. It's almost 15 years that we know that after the administration of the contrast on a technique called ligand enhancement, we get a very typical appearance in amyloid. So on the left is a patient with is a completely normal patient, so the blood is gray and the myocardium is black. And on the right is a patient with cardiac amyloidosis. So the difference is striking. You can see that the blood is black, and you start to see this line of spondylocardial ligand enhancement here on the left, but also on the right ventricle. And this is the typical pathognomonic appearance of cardiac amyloidosis on ligand enhancement. So what we've done with the years is that we've refined the technique. Now with a reconstruction called phase-sensitive inversion recovery reconstruction, PSIR, we've made the technique much more robust. And now we know that we can identify 3 patterns of ligand enhancement. No ligand enhancement, so the myocardium is black. Subendocardial ligand enhancement, there is a line of enhancement here. And then whole myocardium is white, and we will call this pattern transmural ligand enhancement. And why is important to classify the patients with three different groups? Because the more white is the myocardium, the higher is the amyloid burden. So ligand enhancement is really the cornerstone of all our diagnostic algorithm, but the problem is that it's characteristic when the disease is overt. And what we really want is to be able to measure disease processes, identify early disease, and monitor disease progression. And with some of the mapping technique, we can do that. Let's start with T1 mapping. That is the mapping technique that probably is most useful in cardiac amyloidosis. So this one is a non-contrast T1 map. It's done using a SMOLE at 1.5 Tesla. And here, what you see is a pixel by pixel representation of the T1 value. So what is the T1? T1 is a number expressed in milliseconds, roughly proportional to the water content in the tissue. Water content can be free water, like in myocarditis, for example, or water bound to large molecule, like amyloid or collagen. So what happens in amyloid is that normal myocardium that is usually green, it becomes red. So lots of red flags start to appear in the myocardium. This one is a slide where on the x-axis you have disease with an hypertrophic phenotype, so febrile, hypertension, hypertrophic cardiomyopathy, aortic stenosis, and the yellow amyloid. And on the y-axis, the T1. And you can see that there's a mild elevation of hypertension, hypertrophic cardiomyopathy, and aortic stenosis in T1, but actually the elevation in T1 in amyloidosis is extremely high, and you can see that there are lots of red flags throughout the myocardium. And this is the typical appearance of both AL and ATTR amyloidosis on which SMOLE at 1.5 Tesla. So lots of red flags do appear in the myocardium that corresponds to the amyloid deposits on the ligand enhancement images. So here are 16 different patients. So increase in LV mass. So by looking at the red dots into the myocardium, you should be able to spot which one of these is amyloid. There are 2 amyloids here. So is it really that simple? Can we just put the patient into the scanner, just do one single breath hold, non-contrast T1 map, and decide if the patient has got amyloid or not? Actually, the approach can be that simple. And why not? Because T1 is really a composite signal that comes from the extra and intracellular space. And what you want in a disease like amyloid is actually to be able to isolate just the signal from the extracellular space. So this one is diagnostic accuracy in native T1 in patients with suspected cardiac amyloidosis. The study was included more than 800 patients. And you can see the diagnostic accuracy is very high. The area under the curve is around 0.9. But the problem is that you will still get the diagnosis wrong in a good proportion of patients. So can we just use a non-contrast approach in all patients? So what is proposed in this paper is that when the native T1 is very low, with a MOLE at 1.5 Tesla, less than 1036, then the probability of amyloid is extremely low, and you can exclude that with a high sensitivity. When the native T1 is very high, you can then diagnose cardiac amyloidosis with a high specificity. But in all the intermediate range, you should give contrast. And The reason is really because the T1 is a composite signal. And by giving contrast, what you can do, you can actually isolate the signal just from the extracellular space. And by repeating a T1 map post-contrast, you can get an extracellular volume map. So a pixel by pixel quantification of the extracellular volume. And the extracellular volume in amyloid is an indirect measure of the amyloid deposits. So the real advantage of T1 over late-GAD is that we can actually measure the amyloid burden. And this is a very practical example. These are two patients with cardiac amyloidosis. You can see that the increase in LV mass is roughly the same. Systolic and diastolic function roughly the same. So we can think, okay, probably they are at the same stage of disease progression. But actually, when you look at non-contrast T1 is much higher in the patient at the bottom. When you look at the late-GAD, the myocardium is whiter at the patient at the bottom. And when you look at the extracellular volume map, the difference is actually striking. At the top, 40% of the heart is amyloid. At the bottom, more than 60%. And using T1, ECV, and late-GAD, what we can really do is to follow the natural history of disease progression, going from completely normal T1, ECV, and no late-GAD. Then, with a bit of amyloid, there is increase in T1 and ECV, but no late-GAD. And then with more amyloid, the late-GAD becomes transmural, becomes endocardial, and then transmural. And because ECV is a measure of the amyloid burden, it doesn't surprise that it does correlate with prognosis in both ATTR and AL amyloidosis. But can we just measure the amyloid burden in the heart? If you actually zoom out, you can see that when you take the extracellular volume map of the heart, you actually get very often also the liver and the spleen. And here you have two different patients, and the color of the liver and the spleen is very different. And why is that? Because in the patient on the left, there's no amyloid in the liver and the spleen. But in the patient on the right, there's a large amyloid load in both the spleen and the liver. But can we also get a bit more insight in understanding the myocardial biology of amyloid using CMR? So what we thought for years is that actually cardiac amyloidosis can be explained just based on the amyloid infiltration. Then we started to T2 maps, and we noticed that there was a significant elevation of T2 that actually is a more selective signal of myocardial edema in patients with cardiac amyloidosis. And the elevation was higher in patients with AL before treatment rather than in patients with AL after treatment. Then we looked at myocardial biopsy, and we confirmed the presence of myocardial edema, but in the absence of significant inflammatory infiltrate. So why there was edema in these patients? Because in these patients, in the phase of the acute amyloid deposition, the rapidity of the amyloid deposition or the intrinsic toxicity of the light chain cause a damage to the myocardium that independently predicts prognosis after adjusting for the amyloid infiltration. So myocardial edema and amyloid infiltration are really two different mechanisms, but both of them do contribute to disease progression in patients with AL amyloidosis. But can we do something else with CMR to fully understand the disease pathophysiology? When we started to do myocardial perfusion, but more specifically myocardial perfusion mapping, we noticed that there was a significant reduction in myocardial perfusion in patients with cardiac amyloidosis, and the reduction was so severe to be comparable only to patients with 3-vessel disease. But why was that? So first of all, when we took myocardial biopsy, we could confirm the presence of hypoxia with VEGF staining. And when we looked at the mechanisms were quite variable, going from reduction in capillary density to infiltration of the lumen of the intima media of the vessel with actually narrowing of the lumen itself. So why is it important to also look at myocardial perfusion? Because myocardial perfusion is really the final common pathway of many different mechanisms that are probably important, again, in determining disease progression. So what happened with CMR is that we really changed the way we think about cardiac amyloidosis. kind of 10 years ago, we thought, okay, amyloid infiltration by itself can explain the pathophysiological cardiac amyloidosis. And now we have many different mechanisms and many different pathways that in the future actually could become independent therapeutic targets. So with CMR, we can establish a diagnosis, we can understand more disease biology, we can measure processes, but can we track changes over time? So this is a study of more than 100 patients with AL amyloidosis, but this is an interim analysis on 78 patients. What we did CMR at baseline, and then at 6 and at 12 months. And the patients, after the baseline CMR, they started chemotherapy. We classified the hematological response in terms of reduction of the free light chains. This is very standard because the free light chain do represent the amyloid production. Then this is how we classify the hematological response. So complete response, so very good reduction in the free light chains. Very good partial response, reduction in the free light chain is still considered very good. And then there is partial response and no response, where the reduction on the free light chains is clinically not very adequate. The CMR response was classified into regression when there was a reduction of the ECV more than 5%, stability when the change was less than 5%, or progression when there was increase in ECV in more than 5%. Hematologic, so these are the results at 6 months. 60% of patients obtain what we defined a complete response or very good partial response. So from a clinical point of view, this was a satisfactory reduction in the free light chains. But 40% of patients didn't achieve a good response. In terms of CMR, there was regression in only 2% of the patients, with 7% of the patients being stable and 30% showing progression. But what was interesting, amyloid progression was present in 30% of patients, but 50% of these patients were classified as having a very good response clinically. So why this patient did progress? Because probably the hematological response was achieved, but not very rapidly. So in the interim time, there was further amyloid deposition. And this is an example of progression. You can see that after 6 months, there is a significant decrease in ECV, so the myocardium becomes green, and also there is a significant change in the legal enhancement. What about 1 year? At 1 year, 66% of patients achieved a satisfactory hematologic response, and 34% didn't. But from a CMR point of view, you can see that actually there was a significant increase in the percentage of patients who achieved a regression. So all patients that showed amyloid regression were in CR or VGPR, so they had to have a significant reduction in the free light chains. But most importantly, not all patients in CR and VGPR had amyloid regression. So CMR was adding extra information on top of the hematological response. And this is a beautiful example of amyloid regression. You can see the baseline, the CMR is extremely typical of cardiac amyloidosis, and 12 months after, the late-gut has almost normalized, and there was a significant reduction in the extracellular volume. But what about ATTR amyloidosis, the other main type of amyloidosis? Can we see regression also in TTR treatment? This is a small study recently published in patients treated with patisiran. Patisiran is an RNA interference that is associated with an 85% reduction in average on the TTR production. And the 16 patients treated were compared with 16 control. The patients underwent echocardiography, 6-minute walking test, blood biomarkers, and CMR with multiparametric mapping. In terms of echo, there was a very detailed assessment of the cardiac structure, function, systolic, diastolic function, valves, and strain. And there were no significant changes in any of the structure and functional markers at 1 year. In terms of 6-minute walking test and NT-proBNP, patisiran was typically associated with a fall in NT-proBNP and an increase in the 6-minute walking test. But we need to bear in mind that this patient had peripheral neuropathy as well, so the improvement in the 6-minute walking test is also likely to be due to the improvement in peripheral neuropathy. That is a very known kind of known effect on patients treated with patisiran. But what about the CMR? Could we see any change with CMR? This is a typical example of what happens in patients with TTR amyloidosis. That is, after 1 year, you always see relentless progression. These one are the extracellular volume maps, and you can see that at the top is baseline. You see a bit of red and a bit of green. 1 year after, the red is much more than the green, so there is progression. But what about the ECV in patients who received patisiran? Patisiran was typically associated with a reduction in ECV. Adjusted mean difference between groups was minus 6.2% compared to the untreated patients. And this is a typical example of reduction in ECV in patients in treatment. You see at the top the myocardium is green. At the bottom, lots of kind of blue dots start to appear in the myocardium that correspond to reduction in the extracellular volume. We also did bone scintigraphy in the patient treated with patisiran, and patisiran was typically associated with a minimal reduction in cardiac uptake by bone scintigraphy. But can this be reconsidered a reduction in the amyloid burden? We need to be extremely careful, because whilst there was a reduction in the uptake in the heart, there was also increase in the uptake in the bone and different uptake in the soft tissue. So when we give contrast, the dynamic and kinetics of the DPD binding in the bones, soft tissue, and heart of patients with TTR amyloidosis is different, and the change in uptake in any of these three compartments will affect the appearance and calculation of percentage cardiac uptake. So caution should be used in interpreting such images and ascribing changes to ATTR amyloid burden. So in conclusion, the clinical impact of CMR is because we are really imaging the disease substrate. So LGE is the cornerstone of all the diagnostic algorithms, but mapping really adds in terms of understanding disease biologies, but most importantly, measure myocardial processes. And we've seen that we can track changes over time, and that with treatment, we can actually see reduction in the amyloid burden. So should we just use the CMR in all patients, in all situations? The question is not what is the best imaging modality, but which is the best and most appropriate at each step of the diagnostic pathway. Thank you very much for the attention.